I want to welcome all of you to the first of a three-part series of webinars where we'll do a deep dive into our region's mental health crisis with the help of local experts. We'll meet them in just a moment. I'm Laura McHugh. I'm Vice President of Marketing and Communications here at Your United Way of the Greater Lehigh Valley. And I'm really proud to be with you here today, especially on Giving Tuesday, when all of you have made a commitment, even just for this 45 minutes, to be hand raisers and say, we care, we want to learn more, we want to lean in and do more to support the mental health of our community members. Today, we're going to do our first in that webinar series, and the topic is mental health and its impact on the medical system. Few quick reminders. We are recording today, and we will be able to share this virtually for anybody who wanted to join us but couldn't. And additionally, wanted to make sure that you all know that captions are available for anybody who would like them. Just toggle to the bar on the bottom of your screen and click the CC button, Show Captions, and your captions will pop up. So today we'll hear from a panel of experts from our local health networks, all who work in the area of mental health every single day. They've graciously agreed to share their insights and expertise with all of us so that we can deepen our understanding of the magnitude of what's truly being described as the crisis of our time. And that's the region's mental health crisis. We're going to learn how it affects different aspects and different members of our community in different ways. And before we get started with that moderated panel, I'd like to introduce you to someone from our community who's a leader in both the community and specifically in working to combat the mental health crisis. Tony DeRay is CEO of BSI Corporate Benefits, and along with his wife, Adrienne, is chairing our 2023 United Way campaign. Tony, could you kick us off?
Absolutely. Thank you so much, Laura. Hello, everybody. Good afternoon. Appreciate everybody joining. I know how schedules are busy, especially coming back after Thanksgiving. I just wanted to take a minute, obviously, to say thank you to everybody again. Thank you to United Way for pulling this together. I think when Adrienne and I decided to campaign and decided to chair co-chair the campaign, I think the decision to make mental health certainly the focus of the campaign was an easy one. I think most people can attest that mental health is something broad in its scope that certainly covers almost everybody's personal life, whether it's in your own household or in your extended family. It certainly has touched all of us in a lot of ways, and Adrienne and I would be included in that category. Additionally, from a professional perspective at BSI, our company, one of the things in 20 years in business that we never saw before in the history of the company was that mental health has become a part of almost every organization's top 10 claims. So when you want kind of proof, that there's this underlying, everybody kind of knows it, but it doesn't rise to the top that way. That's the proof. And that's what we started seeing about 2 years ago, where these where claims start to hit employer programs in a very, very substantial way in a number of different ways with respect to how mental health can affect almost everything, not just on mental capacity, but also from a physical. So with seeing that across the board, both personal and professional, it was certainly a decision that Adrienne and I had made early on to make mental health a priority. And the two things that we asked the unbelievable staff at United Way to support us and help us with and really lead with was, first of all, breaking down the stigma. How do we get people to understand that it's okay to not be okay, and it's okay to put your hand up in what I'll refer to as a #blessed virtual society. So how can we make it okay for people to be able to put their hand up that way? And then the other thing is the access to care. That's a real challenge as the mental health crisis has unfolded. Access to qualified individuals, like you're obviously going to hear from today, is not the easiest thing, nor is it an inexpensive endeavor as well. So that's what we really have been working with United Way to be able to get the message out about. And certainly there is no better organization, as I'm sure all of you on the call know, that is more equipped and has a broader reach across our community than United Way to tackle the mental health crisis. So it was an easy decision for Adrienne and I, obviously, to make in partnering with United Way. To that end, to whatever degree, obviously, anybody that's on the call can continue to support the campaign. Adrienne and I have offered to pledge $500,000 in a matching campaign, specifically direct dollars to this mental health crisis. So I would certainly encourage you, appreciate again everybody being here today, and certainly on an individual basis, if anybody ever has any questions, that they'd like to ask Adrian and I, we're certainly readily available, but I'll certainly leave it to the experts. So thank you so much for having us.
Tony, appreciate it so much. I've heard you speak about this topic so many times throughout the last several months, and there's so much passion and so much commitment. Thank you for being a real champion. And I know that as you've been out talking about this in community, what you heard from so many others were stories very similar to the stories that you're sharing. And so thank you for bringing urgency to United Way to step up and tackle this. To learn more, wanted to introduce our Chief Operating Officer, Marcy Lesko.
Good afternoon, everyone. I'm so glad you're here. I am so grateful to our panelists for joining us today for this important conversation, this topic that means so much to all of us. And on a personal level, it means even more to me as a survivor of suicide. I can tell you that it is near and dear to my heart that we are raising awareness about what's happening in our local community and also working together to produce some new solutions. I was reflecting on a conversation with one of our community partners yesterday, Valley Youth House, and they were, saying to me that no one is surprised that this is the crisis of our time. This is not something that happened overnight. It's been growing steadily for a while, and now it's reached an urgency of the likes we haven't seen before. We're joined today by that esteemed panel that I referenced earlier, who will be helping us to understand the impact of these issues on our medical system. And it is thanks to information and insights like theirs that we've been able to identify those urgent needs. So the fact that we have our healthcare partners who are leading the way on addressing this issue and be able to tell us what's happening from a medical perspective. I just can't thank you enough for being here and joining us today, and to all of you who shared your lunch hour. So back to you, Laura. Thank you.
Thanks so much, Marcy, for getting us started and for giving us that frame. I'd now like to introduce our panelists and jump into discussion. Joining us from Lehigh Valley Health Network, Dr. Edward Norris. He's the chair of the Department of Psychiatry. From St. Luke's University Health Network, Dr. James James, the chair of the Department of Psychiatry and Behavioral Health, as well as the Division of Addiction and Recovery. Veronica Gonzalez is the Chief Executive Officer of Valley Health Partners Community Health Center, as well as a United Way board member. Thank you, Veronica. And rounding out our panel, Amie Allanson-Dundon. She is the Network Director of Clinical Therapy Services for St. Luke's University Health Network. So a really strong panel of people who are working on this crisis every day in their different networks. So I'd like to start with Dr. James, and I'd like to pose this question to all of our panelists. So first of all, could you introduce yourselves, but also share with us two things. One, the most important thing that you want people to understand about this crisis as they're tuning in today. And two, what are the stories from your workplaces that illustrate why that's so important to you? And we'll get started with Dr. James.
Thank you so much, Laura. I appreciate it. Great to have you all here today, and I appreciate your attention to the mental health needs of our community. As mentioned, my name is Dr. Jim James. I'm the chair of the Department of Psychiatry and Behavioral Health here at St. Luke's, and I also have been a practicing psychiatrist in the area since 2016. First, I'd like to highlight a few statistics that I think help put our mental health crisis into perspective. 1 in 5 U.S. adults experience mental illness each year, and that equates to over 1.8 million Pennsylvania adults, with 450,000 experiencing severe mental illness. As for Pennsylvania's children and adolescents, that's about 300,000 individuals in addition to that experience depression and anxiety. We had a mental health crisis long before COVID, but after the pandemic, I think it's very clear that we've seen higher numbers of people affected by mental illness, and also this is coupled with severe shortages in mental health services that we had never seen before. There are 600,000 adults in Pennsylvania that are currently not receiving mental health care that they need. 53 of Pennsylvania's 67 counties are designated as full or partial mental health professional shortage areas upon ratios of population to professionals available. Lehigh, Northampton, and Montgomery counties actually don't make that list. Yet I can tell you confidently that the services present and the access to them in these counties are deeply missing the mark as well. I have 3 stories to illustrate important challenges that I often see. The first is about access. An overwhelmed new mom having thoughts of suicide has no connection to mental health services, and she turns to the emergency department. It is determined that the only safe option for her is to be admitted to the hospital. It breaks her heart that she must leave her daughter with her relatives, but she sees no other option. However, a few days away from her daughter feel like years, and she decides that she needs to be discharged, against clinical recommendations, of course. She is connected to outpatient services, but the soonest available therapist is 2 weeks out, and for psychiatry, it's 8 weeks. We strive typically, historically, to have appointments within 10 days of discharge, but that's no longer really feasible. What is worse is that she's actually lucky because people in the community can wait several months for any of those appointments to be made. But where she is unlucky is that she's sent to the same situation and stressors that she was facing a few days before, prior to the stabilization that she received over a few days, a prescription, and ultimately untimely follow-up appointments. Another example is of a 25-year-old man with schizophrenia. He and his family were unfamiliar with mental illness, and so when his symptoms started, it led to strained family relationships and not receiving access. And so he left home. Now homeless, his condition deteriorated for years until the Allentown police found him walking in traffic after being assaulted. He was transported to the emergency department and admitted to the hospital. To be successful at discharge, he needs an assertive community treatment, or ACT team, as well as housing options. But both are backlogged for months. An expedient, quote unquote, housing is to send him to a homeless shelter, where he'll likely deteriorate again. And on top of that, it's something new of a trend where homeless shelters actually are turning away people that are on medications for mental illness. So not really an option anyways. So where does that leave our young man? Well, it's the same situation that we actually currently have for several patients in our network right now. He remains in a holding pattern for discharge that could mean hundreds of days or sometimes even over a year of staying on a short-term inpatient treatment unit. The final story of what I see as an outpatient psychiatrist. A parent is a fairly new person to treatment and could have used it for years. Tight finances always led to difficult decisions, so even if they could rise above the family stigma towards shrinks, priorities were always towards paying the bills or the children's needs. They work hard to be the best parent they can, but without the right tools and resources available to them. Now they're in treatment and following every recommendation. Yet despite their greatest efforts, their children resultantly have experienced the lost opportunities to be their best selves. It's a cycle we need to stop. Half of all mental health starts by the age of 14. And upwards of 20% of the general public experience clinically relevant mental health problems before the age of 25. Services to youth are critical, and that needs to be addressed as well. But they do not live in a vacuum, and we need to treat the whole family.
Dr. James, thank you so much. I wanted to make sure I gave you the chance. I really appreciated in your examples how it covered so many different individuals and types of individuals who are being impacted. Veronica, what are you seeing, and what do you think is the number one thing you'd like people to walk away with today?
Sure. So hi, everyone. Veronica Gonzalez, CEO of Valley Health Partners Community Health Center, and a proud member of the United Way Board of Directors. So I'm going to focus on a topic that actually already came up today, and that is the stigma around mental health that really exists across the country. It's not any different for us here in the Lehigh Valley. And I will say, I think we've made strides in this space since the pandemic. It's really forced a lot of conversations. Look at us here today, but we still have a long way to go. In the Lehigh Valley, and specifically for us at Valley Health Partners, we're servicing the Allentown area that has a majority minority population, predominantly Latino community, who are disproportionately impacted by both physiological and behavioral health disparities. And they certainly face a stigma around mental health. So many of our patients, they'll tell us that they believe if they see a therapist or a counselor, that they're crazy, or that's the belief of their family or their spouse. And certainly that stigma, right, really occurs as people have those negative thoughts and beliefs. And in return, what we have been seeing is a 50% broken appointment rate in our mental health appointments. So patients that we're referring to see our behavioral health specialists for therapy, they're not prioritizing their mental health as much as they're prioritizing their physical health. Now, we are a federally qualified health center, and what that means is we take care of the most vulnerable community members, and we provide care that's culturally competent. We meet patients where they are. So we have been intentional about standing up structures that help to combat the stigma. And our behavioral health team, led by Tommy Acevedo, he's our director director of integrated behavioral health, he also works with his team to be intentional about addressing and acknowledging the stigma, right? So at every new patient intake, they're asking patients about their experience with mental health, using that as an opportunity to really shift the narrative and the perception. And then our structure is that we have integrated behavioral health specialists in all of our primary care practices, including our women's health practice and our 2 school-based health centers with the Allentown School District. And what that does, it really removes the stigma around the location of care. So no one knows why I'm going to see the primary care doctor. And many of our patients have shared that with us. They're so thankful that the service is available in their primary care office. And also many patients tell us, look, I don't necessarily think therapy is going to help me. My spouse thinks this isn't a good idea, but I trust my primary care doctor. So I'm here and I'm willing to give it a try. So really leveraging that relationship with the primary care doctor and encouraging our primary care clinicians to really manage up the need and the importance for mental health as is physical health. And so I think really that important takeaway is that the stigma is there. We have to acknowledge it. We have to be intentional about how we address it in healthcare. So 2 quick stories tied to the stigma we're seeing in our community. I'm going to share one from an adult and one from a child. So a 10-year-old patient in session with behavioral health provider thanked the provider for providing the space to talk about her feelings. Patient acknowledged that in her household, a Latino household, sharing of feelings and expressions of emotion are frowned upon, seen as a weakness. Therapist helped a patient acknowledge the importance of mental health maintenance. Powerful moment was when patient's mother also reached out to therapists, thanking them for helping change these fundamental beliefs in the family unit. Mom is now connected to a VHP adult therapist. And I do want to add, we serve over 30,000 members of the community. The majority are children. And we have seen quite the increase in the need of mental health services for children, even under the age of 14. And quite frankly, we have a lot of children who are ready to engage in therapy and they're open to it, but the parent isn't. And the parents often come with multi-generational trauma, right? Which just adds more layers of complexity. And then a quote from one of our adult patients: "I come here for me, not for my husband. When I first told him about this, he told me I was crazy and it would never help. It's been 4 months and he has seen such a change in me. He reached out to his doctor for a referral."
Thank you so much, Veronica, and I really appreciate those examples. I really want to stress that Valley Health Partners, St. Luke's, Lehigh Valley Health Network, Star Clinics, all of the organizations that are represented here today through the health networks, all of them are already working in coordination with United Way to get services to people where they are. So what many of you may not know, or maybe you do, is that many of the clinics that Valley Health Partners have, and Star Clinics as well, are co-located in United Way community schools so that students and families are getting that support right there, and there's real access and referral that's happening there in real time, where families already feel like they have a safe environment. So Dr. Norris, I'd like to hear more from you on this topic. You're seeing things across a really broad spectrum.
Sure, absolutely. And as noted from our earlier speakers, COVID-19 didn't bring about this mental health crisis. It really focused a spotlight on what already was a challenged system. And that's because there really are very few limited long-term care solutions. Dr. James pointed out how the state hospital beds are fewer and fewer. The closure of the state hospital system, as they downsized it from a Commonwealth standpoint, was supposed to increase the ACT teams or community services to help support people in our community. And in reality, that could be more robust. As we all know, there's no free market solution. If there was, we wouldn't be having this conversation because we'd already have this crisis solved. And as part of that lack of a free market solution, half the psychiatrists in the country actually don't take insurance. And I think everybody on this call and all of the panelists are all dedicated for the people who don't have a healthy credit card, who can't pay for the services that are available for those groups that do treat just a healthy credit card. And that's not the group that we're focused on. And then finally, there is a shortage of providers, and we're continuing to try to expand that. On top of this baseline challenged system, we had COVID-19 occur. And COVID-19 increased the burden of psychiatric illness. It increased depression and anxiety. It definitely increased substance use. And with that, there were more patients who were suffering. And then the effects of the COVID-19 financials really came in like a tsunami. And as the tsunami receded, there were just fewer community resources and fewer groups that were able to support patients with significant mental health issues. We've seen a number of agencies that have closed or significantly reduced their ability to provide services. That's also challenged by the difficulty in staffing related to just the great resignation of many groups. So all of that has led us in the Lehigh Valley to have fewer community supports, which results in ultimately more acute psychiatric crises. So since there are fewer options, patients are presenting to our emergency rooms in an increased state of psychiatric need. And that's really not an optimal environment to treat patients. And so many of us have had to pivot to around how do we treat patients on our medical floors or our emergency rooms that are suffering acute psychiatric crises. And I know that many of us have shifted resources to these acute settings to help stabilize people because there aren't enough psychiatric beds for acute psychiatric illness. And if we can help patients to be stabilized in other settings, perhaps they don't need a full inpatient psychiatric stay. Perhaps they could be transitioned to a residential or a partial program. In addition, it's caused most of our groups to look at what can we do to increase throughput for psychiatric patients. And the traditional model of psychiatric care needs to be augmented with really that partnership with primary care. And how do we support primary care providers to be able to do more and assist them so that they are comfortable providing care in their practices to more complex patients with psychiatric illness. And we've done that through a variety of models. It's already been mentioned that there are therapists, embedded behavioral health specialists that we can put in primary care and specialty offices to help support those providers. We also link them in with psychiatrists to also augment their medication management. All of this is a shift into primary care to help primary care do more. And then, of course, as we do all of that, it's always an opportunity for us to improve our communications, both across our internal psychiatry divisions as well as across our different hospital networks, as many patients with psychiatric illness present not only to one hospital, but often many of our hospitals. And the better we communicate about patients and their needs, the better care patients get. And then finally, one of the odd blessings of COVID was the increase in telehealth services and the ability for us to turn on our telehealth services to so many places. And so it was pointed out earlier, we're very fortunate that Lehigh and Northampton counties are actually not in the shortage areas defined by Pennsylvania, but many of our counties to the north are. And so the ability to leverage telepsychiatry to get to other places outside of the physical location of an office is better for patients everywhere in our entire area. And then just closing, as we look at our referrals for outpatient care, starting prior to the pandemic to this year, we at LVHN have seen an increase of 320% of patients looking for outpatient care. And I see others nodding. I think we've all seen similar increases in just the demand for outpatient care. And so we need to continue to think differently and expand and partner with others to provide more and more care. So thank you very much for being here today.
Yeah, Dr. Norris, thank you so much. Amie, what would you add?
Hi, thank you guys so much for having me. Network Director, Clinical Therapy Services at St. Luke's. I'm a licensed professional counselor. I'm a certified clinical trauma professional and advanced alcohol and drug counselor. And, I think the biggest thing I can share with you guys from the perspective of a psychotherapist would be that all the therapists I know have experienced a demand for therapy that is really like nothing that they've ever experienced before. Every available time slot we can offer is filled. And as Dr. Norris just shared, the wait list grows and grows and grows. So we are just like Lehigh Valley, we are all working together to think outside the box and figure out how we can get people the services that they need and quality services and do this the right way. There's also a staffing shortage, just like everywhere else. That's not just for mental health, that's everywhere, really. There's kind of a little bit of a staffing shortage, which then doesn't help that situation. I think just two stories that I don't want to necessarily say that they're individual stories. We've seen this a lot, but two things that can highlight that really are the increase we've seen in domestic violence in the Lehigh Valley and domestic violence situations. And one of the things that I'll tell you a story. I mean, telehealth has been fantastic, but telehealth can be a detriment when it comes to psychiatry and psychotherapy, especially when we're talking about victims of domestic violence who maybe are now seeing their provider on screen rather than in person. And sometimes on screen, abusers or people they're living with who are abusing them can hide themselves or situate themselves in a room during in a session so that they're not seen, and make it real difficult for people in a domestic violence situation to be able to be truthful with their provider or their psychotherapist. So we've seen telehealth not always be a blessing as we've kind of rolled this through. And that's not just one instance, that's many, many instances for children and adults alike who are abuse victims or abuse survivors. I think I'd also then piggyback and talk a little bit about kiddos, right? And the increase in stress and anxiety and depression that we've seen in the kids across the Lehigh Valley. Family disruptions with parents working hybrid or staying home. Kids that maybe academically and developmentally during the pandemic didn't get what they needed, so we're trying to play catch up, and it just affects everything else. And socially, we're seeing some inequities with kiddos socially that have come out of the pandemic. So all of that together, coupled with all the stats and the things that the other panelists have just said, I think really do just highlight some of the issues that we're seeing.
Yes, thank you all for your thoughtful responses as we kick off this conversation. Dr. Norris, I wanted to ask you specifically, it's come up a little bit in each person's response to that initial question, but how did COVID-19 ultimately impact several different types of populations and several different groups of community members here in the Valley?
Certainly. During the pandemic, we actually saw, 41% of U.S. adults experience high levels of distress at some point during the pandemic. And second to adults, adolescents, young adults, women, and people in lower income households were more likely to experience this distress. According to the CDC, over a third of our high school students reported mental health challenges during the pandemic, and this included roughly half the girls at around 49% and a quarter of the boys around 24%. And this same pattern appeared with those suffering from anxiety and depression, as those who experienced household job loss. Young adults, adolescent females, and women were more likely to have these symptoms. And unfortunately, we also saw an increased number of deaths related to drug overdose. And these overdose rates were the highest they've been in our history. But there is some hope. It's a hope that the understanding and the challenges of mental health and its effects continue to be discussed and ultimately will help continue to lower stigma about these illnesses and increase people's willingness to obtain services. In 2022, an easy to remember hotline for suicide and behavioral health crises, 988, was launched, and this was launched to increase access to immediate mental health assistance. In response to the growing mental health concerns affecting our youth, the integration of mental health services into school-based settings has become a priority. And I know many of our groups, including ourselves, have multiple therapists in many schools across the area. And finally, history has shown that the mental health impacts of a disaster unfortunately outlast the physical impacts, suggesting that today's elevated mental health needs will continue well beyond the end of the outbreak. And technically, we have ended the outbreak, but as we are all experiencing, we need to remain diligent about the importance of mental health as well as substance use services.
I appreciate that. Thank you so much, Dr. Norris. Amie, would you mind sharing a little bit more about what you're seeing showing up in the rural communities, Carbon County, for example, some of the areas in the Slate Belt as well?
Yeah, I mean, rural residents really are significantly less likely to receive any mental health treatment than our urban residents. Only a third of those with diagnosable disorders seek mental health treatment services. There are fewer mental health providers available in our rural areas. They just aren't as prevalent, aren't as available. Most mental health professionals practice in more metropolitan or areas that aren't quite so rural, and as a result, more than 60% of our rural folks live in designated mental health provider shortage areas. So you take all the problems we've already talked about, and then you put somebody in a rural area where there's no providers, it makes it really difficult, right? So consequently, rural residents have greater transportation needs, accessing mental health services out of town. We know in Carbon, Schuylkill, Monroe, there's not really even any Lyft or Uber services to speak of that help them get where they need to go, right? So other factors that make it hard for our rural residents to access mental health services really include levels of insurance coverage, right? Uninsured or underinsured, and persistent poverty rates that create substantial cost barriers. Carbon County has the highest rate of veteran suicide in the state of Pennsylvania. So, one of the issues that we're facing in counties like Carbon County is, reaching our veterans, and then, consequently the families of those veterans, and helping the trickle down trauma, the multi-generational trauma that happens. And then in rural factors, we're compounding it with all those other issues, right? And then I would say the stigma of seeking mental health services still exists in rural areas. Sometimes I think even still worse than we're seeing in kind of the more Allentown, Bethlehem, Northampton, Lehigh counties. Traditional values like self-reliance and independence also prevent rural residents from seeking professional help. And a stat that I saw that I thought was really fascinating, and this is Schuylkill County, which isn't Carbon, but it borders that, right, is that the ratio of mental health care providers is 1,210 to 1. 1,210 to 1 in Schuylkill County. It's 450 to 1 in Pennsylvania, 270 to 1 for United States top performers. So it's a huge problem. If I go back to my domestic violence point earlier, we know that and this is just in Carbon and Schuylkill counties, 35% of LGBT individuals in Carbon and Schuylkill counties reported to being the victim of domestic violence. Those are the ones reporting it. So really we're seeing all of the issues and then more. The opioid epidemic and increased rates of substance use since the start of the pandemic are contributing to drastic increases in the need for care and services for mental and behavioral health, with really overdose rates in our rural areas increasing 18.2% since the start of the pandemic. So really, food insecurity, also we're seeing social inequities, food insecurity. And if somebody isn't eating right and doesn't have the right nutrition, it's going to be really difficult for them to take care of depression or anxiety or a mental health disorder when, in terms of the hierarchy of need, food and shelter come first. So we have to help folks meet those basic needs before we can kind of get them where we need to be with their mental health. So it really is compounded in our rural areas.
Yeah, Veronica, I know a lot of the work that you do is around the social determinants of health as well, and you're seeing it more in our urban cores. Veronica, what would you add to that conversation?
Yeah, I mean, a lot of what Amie just said there at the end. So, a big part of treating the patient as a whole is addressing the physical, mental health, and the social determinants of health. So, we actually know that 80% of what influences health outcomes are the social factors, right? Where we live, where we work, the food we eat. Only 20% is influenced by healthcare. And so, at Valley Health Partners, similar to what Amie said, we often talk about Maslow's hierarchy of need and how can we expect our patients to be at the top of the hierarchy if they don't have that baseline foundation of their physiological needs. So they don't have food, water, or shelter. And again, as mentioned in the Allentown community, there is that disproportionate influence we're seeing in terms of social barriers. So what we do at Valley Health Partners, we do have a standardized social determinants of health screener, and every new patient is screened to help us understand what are the social barriers the patient may face throughout their care. And we really rely on community partnerships. So we have over 100 different community partners, the United Way, many community-based organizations, churches, government agencies, the school districts. It really has to take a village because we're experts in healthcare, right? We're not experts in transportation, food insecurity, housing, et cetera. And I'll tie in a quick story that I think really illustrates. So we have a 71-year-old patient who had been referred to behavioral health by the primary care doctor 5 times in the last 4 years. Consistent pervasive depression. Patient no-showed to 3 appointments previously and discontinued treatment after his first intake. Valley Health Partners therapist connected the patient to one of our social workers who identified transportation was the issue and telepsychiatry was not an option. Social worker intervened. Patient successfully discharged from treatment 4 months later with a drop in baseline depression from 22 to 7 at discharge. Patient acknowledged at the end of treatment that the perception of people thinking he didn't care or he didn't want to talk because he wasn't showing up to his appointments made him feel judged and even more depressed. And he was thankful for the transportation barrier being removed and allowing him to engage in care. So again, that root cause, right, of really even being able to start the mental health treatment couldn't start without us looking at the transportation barrier.
Thank you, Veronica. And that's so much of the work that we're doing here at United Way, really supporting those basic needs, making sure that kids have access to food, to housing, that seniors have access as well, that there's resources that are available throughout the spectrum of the lifespan. Dr. James, I'm curious because you talked about this earlier, the issue of understaffing and the lack of professionals available. What role does underfunding play on making resources available to everyone who needs them in the Valley? Dr. James, I believe you're still on mute.
I just got too excited. So I want to say, I first want to recognize what Veronica said about 20% being, associated with healthcare as far as people's outcomes. That is so hugely important when we look at funding and reimbursement and resources and supports if we're going to really tackle this the right way. I mentioned previously that Lehigh and Northampton counties are not considered mental health professional shortage areas, which is true. But mental health services in these counties and the rest of the Lehigh Valley are deeply underfunded. Counties provide many services, including school assistance programs, support hotlines, community education and outreach, and prevention efforts. Yet county-based funding has not increased since 2008. And in fact, it was cut in the 2012-2013 Pennsylvania budget. So we have staffing shortages and underfunded programs with limited bandwidth for something that is in high demand. To Dr. Norris's point already, ever since COVID, even worse. We're looking at the payment models that we have for reimbursement and mental health parity. One barrier to parity is that payment for services is heavily weighted towards procedures. And mental health really doesn't use a lot of procedures, if at all. Take that with the poor reimbursement rates for psychiatry and therapy, and you have an unprofitable proposition. In fact, generally speaking, outpatient psychiatry and psychotherapy for networks such as mine are provided at a financial loss. We do it, of course, because it is needed, it's the right thing to do, but it's hard to recruit new providers and grow services with such headwinds. On top of this, consider that commercial insurances exclude certain professional certifications in their pay structure, requiring us to utilize higher cost professionals to do work other less costly professionals, clinicians could do. Thus, we either do not get reimbursed for all the services that we do, or we're forced to use an individual that costs significantly more than the reimbursement justifies. For example, commercial insurances do not pay for brief therapy interventions and crisis services provided by those with a master's of social work or licensed social worker training. In fact, commercial insurance don't pay for ACT teams mentioned previously, family-based services, residential services, case management, and other needed services. This is left predominantly to Medicaid. And to put it bluntly, the system is forcing people with mental illness to fail to the point of disability and qualifying for Medicaid before they can access many important services. I can tell you of countless individuals that I've seen in an outpatient setting that tell me that resources are slim, that they can't afford medications or treatment, and that the programs that they have out there that are supposed to be helping them are backlogged or now not even existent. Despite expending great personal effort to help themselves, they are not finding the help that they need. And by the way, their obesity, hypertension, diabetes, and other medical issues, they're worsening because poor mental health is directly associated with poor physical outcomes. So human costs and economic costs are ballooning when the mental illness reigns. We need to fix our reactive high-cost program of how we do healthcare in our country and also our state, our Commonwealth. We need to fix this reactive process that we go through. We talked about it already. Many of us already shared that we're looking at people flooding the emergency departments, being stuck on medical floors when they should be on psychiatric units because there's no space for them. But this is the acute model that we've always been focused on in our system. We need to focus on being proactive. If we invest in education, early detection, early interventions, and also, as Veronica said, the whole continuity of need for an individual, we can reach people when the light has not yet gone dim. It is heartening to see you all here today, truthfully, because I do hope, and I have hoped significantly because of all that I know from seeing you here and your interest and the people that I see working hard in the healthcare community, and because I see solutions and people are starting to take notice. But notice also requires action through advocacy, services, and funding. And so today we have a chance to help those battling with illness to connect with the fuel that they need to fight the darkness. And you and us together, we can help shine the light to illuminate the path forward for every Pennsylvanian. Thank you.
Thank you so much, Dr. James. Marcy Lesko, I can tell you have a lot to add to this, but before we get to you, I really just want to give a great deal of thanks to Amie, to Veronica, to Dr. Norris, and to Dr. James for sharing your time so generously, your valuable insights, and of course, your partnership with United Way to serve the people throughout our community. Marcy, I heard a theme of hope and I heard a theme of solutions, and I know you have a lot to add to that.
I do. I was messaging our team and telling them how proud I am of them for bringing this panel together. This is the first of its kind for us, and the fact that we have our health network partners across the board and to hear from your expertise. We're joining you. You've been leading the way for a long time. We're joining you in the work that you have been doing so well, and the things that you know that are important in our community. So as we launched United for Mental Health this year with really at the request of our campaign co-chairs, Tony and Adrian DeRay, and all of our community partners, from healthcare to education to, across the board, as we've been talking with folks about this, we have heard a lot of interest. And we've also heard a lot of folks who've said privately to many of us, me too. Many of you, even on this call, know someone and love someone who is struggling and have survived some of the things that we've talked about, and sometimes even understand the day-to-day toll that it takes on your own health and well-being as you are caring about and loving someone who is battling mental illness. So what is United Way going to do about all this? What are we doing to help? As I said, we are not walking into this with any preconceived notion that we can solve it. If any of us here had that, we wouldn't have to be in this conversation. So what are we going to do? Well, first and foremost, we're using our platform with our annual campaign to raise awareness. And I can't thank Tony and Adrian enough for leading the way with that. You've challenged us to do that, and we are. And so we are, this is the first of 3 webinars that we were going to be hosting specifically specifically inviting our donors and our closest partners in to this conversation. We've intentionally kept them smaller so that we can have these conversations. So we're raising awareness about what's happening and sort of, again, this crisis of our time. We're raising money. And so we are encouraging people to join us in investing in tried and true solutions, as well as some innovative approaches at the community level that can help families in a lot of different ways. Our specific areas of focus are going to be children and families. We're talking with folks, across the board. This is hitting the nail on the head. Our kiddos are struggling harder than they ever have. And the data is across the board. And then anecdotally, we're talking with superintendent a few weeks ago, and she says, do you know that at my high school, we have one social worker for 3,000 kids? One. And when we think about the overwhelming needs that our kids and families are presenting with in a variety of spaces, it's just not enough. So as we're thinking about a provider pipeline, which is not an area that we work on, we know that we need more people that can provide care and support. It's not an area for us, but what we know is that we can help do some stem the tide, provide some prevention-based programming. We can also provide some light touch intervention type programming as we're working with our healthcare partners on the much more robust approaches. We're going to investing in, so children and families is our first pillar. Second is around veterans. I live in Carbon County. I live in Palmerton, and I can tell you how devastated we are to know that we are number one in the state in veteran suicide. It is an area that we all care deeply about. It's a community that is very proud of who we are and what we do. And to know that those who've given so much for our country are suffering in this way is disheartening. And so we know that we can do more and do better. And then our third area of focus is with older adults. We know that our seniors, social isolation is real and it takes a toll on folks. And, there's a lot of assumptions about what seniors need and how those needs are being met by a variety of services. And so we'll have more to come on the things that we're going to be doing in this space with our community partners, with our healthcare partners. I can't thank you all enough for joining us today. We are proud to be shoulder to shoulder with you and joining this. And I would ask those of you who have joined us who are interested in our United for Mental Health campaign to consider offering a gift. We'll be sending out a follow-up note with an invitation to give. Any gift matters, and it will help us to pull down that match that BSI and Tony and Adrian have so generously offered, and allow us to invest in solutions that make a difference. So thank you all for being with us today, and back to you, Laura.
Yeah, thank you. Just want to echo Marcy's thanks to all of our panelists for joining us today, for truly being united for mental health, and for all of you for spending your lunch hour learning more. It shows how much you care, and especially today on this Giving Tuesday. I do want to share the dates for our next two webinars coming up on January 17th. We'll be doing a session focused on the education system. Marcy talked a little bit about it. Some of our panelists did as well. I see Tracy Herner was on the call from Bethlehem Area School District. Lots of work happening and the impact that it's having on our mental health of our students and their families. And then suicide came up multiple times in today's conversation as well. So we'll look more closely at that in our third and final session on March 7th. And of course, the information is available on our website to go ahead and sign up, and we can send that out to you as well. So thank you again, and have a great Giving Tuesday.